begin just by way of introduction. Well, first and foremost, we want to thank you for joining our live webinar today, Treating Pain in 3 Steps with the Edgework Approach. My name is Kristen Cederland, and I'm the director of the WorkWell Quality Provider Network at WorkWell Prevention and Care. Our mission at WorkWell focuses on workplace injury prevention and management. We partner with healthcare professionals and employers all over the country to provide the necessary training, coaching, and education programs that help support this mission. As you'll see on the screen here, over the last 25 plus years, WorkWell has trained more than 10,000 therapists in our FCE, FJA, and pre-work screen programs and methodologies. Members of our WQP network have access to training programs, resources, and clinical support to help them provide high-quality injury prevention and management programs in their communities. Sorry about the dogs, guys. I'm thoroughly embarrassed. Through our partnership with employers, WorkWell is also able to provide referral opportunities to our WQP network. For those of you who'd like to learn more, we invite you to ask us about our new WorkWell Easy Train subscription membership. Like I said, we'll have an opportunity for Q&A after Cory's presentation, and feel free to go ahead and put questions in the chat window at any time. And if we end up not getting to all the questions, we'll be sure to follow up after the conclusion of the webinar. So we are very privileged to have today's speaker, Cory Blinken, as a longtime member of our WQP network. I've gotten to work with Cory very closely over the last several years through a couple of our on-site programs in the Pacific Northwest. He's done a lot of research and speaking on the topic of pain science and has successfully implemented those concepts into his approach to patient care. So without further delay, I introduce you to Cory Blinken. And I'm going to go ahead and turn over the screen to Cory. And Cory, you should be able to take it from here.
All right, let's see here. So, good morning, everybody. First of all, thanks for joining in. These webinars are kind of always an interesting way to do this. I don't have faces to get feedback from, so I can't tell when I've said something that made you mad. But on the plus side, you don't have to look at my ugly mug. So hopefully we'll have good sound connection here the whole time through. So hopefully what we'll get to today, this is kind of a broad topic that that I usually spend a lot of time over the course of a couple of days talking about, and we're trying to condense it down into a short little webinar. So I've tried to kind of distill it down into a few topics that will kind of give you an idea of what this is about, what it is that you're trying to do, and then also with some walk-away stuff, some things that you can actually take back and try and implement and kind of see for yourselves. So what we're trying to introduce here is really kind of a framework, and I call it a 3-step framework for treating pain. Obviously, treating pain cannot be as simple as 3 steps of anything. These are really complex problems, but in an effort to simplify that, I've tried to break it down into kind of 3 big kind of framework type processes that I hope will kind of help people simplify all of that down into a more workable format. So let's see here. There we go. Okay. So like Kristen said, my name's Cory Blinken. Just a quick little overview of me. The little jumping guy on the left, that's the logo for my company, Forward Motion Physical Therapy. I've been a physical therapist since 2001. Started off in Indiana, worked out into the Northwest. I now live in Vancouver, Washington. And like Kristen said, I do a lot of on-site work at this point. I've worked closely with WorkWell over the years, and like she said, I am a WorkWell quality provider. If you go all the way to the right side, you'll see the logo for the Pain Science and Sensibility podcast. That's a podcast that I do on a monthly basis. I co-host with another physical therapist named Sandy Hilton out of Chicago. And Sandy's kind of a big name in the women's health or pelvic health specialty arena. And if you're online anywhere, you probably run into Sandy somewhere or another. But we do that through the PT Podcast Network. And then in the middle here, I also do, I'm on the faculty at Modern Pain Care. I've got a couple of little online courses and things like that that we do through Modern Pain Care. So that's just kind of me in a quick little nutshell of some of the things I do. And just to put some of this into context, the types of people that we're focusing on are just to kind of give us a background of something to talk about these things within context. This might be the person who comes into your clinic and they've got back pain and they've maybe been through the system a bit, and really there's just a lot of distress about the whole scenario. They might be distressed about, is this something that's ever going to get better? They can't really seem to find anything wrong with me. This is a non-specific back pain type of problem, or maybe they had a surgery and it didn't go well. And they're just really struggling with what this is going to mean for them moving forward. This thing has probably changed the way that they interact in their job and in their home and in their social life and all kinds of things. And these are just kind of some of the tough presentations that we see that we really can have a hard time working with. And one thing I really try to reconcile is this idea of, we see a lot of the predictors around who gets better with treatment or who gets better in general with pain. A lot of them are psychological type principles. And I think a lot of times therapists, we kind of have a little bit of a discomfort level of knowing how to incorporate that into our practices. What are some ways that we can take that information and make it fit with some other things that we already do well as physical therapists? There's just sometimes a bit of a comfort level issue there. So, this is also a bit of my effort to try to bring some of that stuff into a usable format with some of our physical practices. The other thing about, the person who comes in with back pain, this might be one of the concerning things, is that this might be their job. They might have to be in a position or doing some tasks or doing some things that really require a lot of their back, which can make it real worrisome as to when or if they're ever going to be able to get back to work. Another good example, one I heard somebody else use at a presentation one time, was folks who had to load full kegs of beer into the back of these delivery trucks, and they had to lift them by hand. And just, imagine if you had somebody who, in order to get back to working full time, had to be able to lift a 180-pound keg from the floor or from the ground up onto an elevated truck platform. That's a really scary scenario for that person. It's hard for the therapist. You're going to be working with that person for a long time, most likely, to get them back to that kind of a capacity. So, there's just a lot of things that go about this that are not solely about what's going on in their back structurally, with their soft tissues and some of those things. There's a lot of other variables that are wrapped up in this. So there we go. Speaking of psychological principles, one that I really like to talk about because I think it's really important is this idea of confirmation bias. The confirmation bias is this concept that people tend to look for things that confirm a belief that they already have, right? And there's all kinds of really interesting things that you can work through on this, but this is not a problem. This is not something that people have an impairment. When there's something wrong, they tend to do this. We all do this. This is just part of being a human, right? We are just wired to look for patterns that confirm the thing that we already think. Okay. So, where this becomes important is the person that comes in and their beliefs are wrapped around this idea of this is something that might not get better. And this is something that must really be bad because I'm not getting better. And this is something that I can't change. I need help from somebody else to be able to get me through this. Those are important things because they all are beliefs. And so they are all going to be in the realm of this, of the possibility of being in this realm of confirmation bias. So some really important things. I mentioned how important some of these psychological predictors are. and this is just a real recent one that came out. There's a whole bunch of really good research that talks about how good of a predictor self-efficacy and recovery expectations are in terms of when a person and whether a person is going to get better. Basically, one of the biggest predictors of whether or not somebody is going to get better in physical therapy is whether or not they expect to get better in physical therapy, right? So that's both kind of, it's an interesting finding, but it also is a little bit scary, right? It means that the person that you're working with kind of needs to expect that you're going to be able to help them before you're going to be able to really help them, or at least that's a big predictor. Another big one is self-efficacy. This is really kind of one of my favorite things to focus on. I think this is kind of the great equalizer as far as when you're thinking about what you're going to do with your patients. Having a focus on self-efficacy can really be helpful. What it is, self-efficacy is just this concept that a person can bring about the outcome they're looking for with their own internal resources. That is paraphrasing, but kind of consistent with Albert Bandura's original concept of self-efficacy. When you see it in research, it's usually talking about what's called pain self-efficacy, and the research definition is usually a bit more simple. It just says, basically a person's willingness to keep functioning despite pain. So you see these things as consistently high predictors of whether or not a person is going to be able to get through their problem. So the question is, for one, can we impact these things? There's good research out that says recovery expectations can be impacted. Self-efficacy is an interesting one. There was a study that came out last year that talked about self-efficacy might be more of something that we're born with than what we previously realized. We've always kind of approached it as being something that was very plastic and can be very much manipulated from situation to situation. But there's some research out there suggesting that people kind of are born with differing levels of self-efficacy. My approach to this at this point is that, kind of like everything, we all act in different ways depending on the situation that we're in and the role we're playing in that situation. We might or might not be able to increase the pure amount of self-efficacy that a person has, but we can encourage them to use whatever resources that they do have. In other words, we can kind of try to get them working in the direction to where what self-efficacy based behaviors they already have, we can try to cater them towards those directions. So in other words, I think both of these things are impactful. One, they're important, and for two, they can be changed, or they can be worked with in a therapy setting. So, what do we do about this? So, when a person comes to us and they've got a belief that something is really bad or that something is wrong, maybe the person comes in and says, hey, my back, this is just something that's not going to get better. I must really have something wrong back there. The instinct might be to tell them why that is not correct, right? To just give them a bunch of information. This has been a big direction of pain science education for quite a while now, where we're really trying to focus on giving people more accurate information about what's going on with pain. What does the science tell us about how pain works and how it doesn't work and things like this. And there's a real big temptation, or there's a big opportunity to just lay this information on people, right? Tell them why that way of thinking is not accurate. But the problem with that, and what we run into in the clinic, or at least I've run into this several times and talking to other therapists, I think it's fair to say that this is something that happens a lot, is this idea of pushback, right? And this is consistent with this idea of the backfire effect. And what that says, the backfire effect says that when you currently have, or when you run into information that contradicts something that you already believe, the chances are that instead of changing your belief in the direction of that new information, you're just going to entrench even more so in the belief that you already have. And for anybody who doesn't understand this, when we're done with the webinar, just go onto Facebook, and whatever your political bent is, one way or the other, just go find somebody that's on the opposite side of that fence and try to talk them out of their position, right? It's just not likely going to go well, right? And when you do that, come back and let me know how successful it was. But we can kind of see how it would play out. It just doesn't work very well to try to talk somebody out of a position that they don't already realize, or they don't have some kind of inkling that they need a new way of thinking about it, right? it sets them on the defensive. This is the way I like to think about it. When you try to tell somebody why they're wrong, they're not going to say, oh, okay, well, it makes sense I'm wrong. They're going to say, no, these are the reasons why I'm not wrong. It's just going to automatically set them on the defensive and look for reasons that confirm the belief that they already have. So this relates to confirmation bias. Okay, so this tells us that maybe just dumping a bunch of information on people might not be the most effective way to bring these things about. So, what are we going to do? How do we get around this problem of people when they have these beliefs that are getting in their way, but they just don't see how that's happening? We can run into a brick wall. And the way that I like to go about this is this concept of this 3-step framework. Okay, so the 3 parts of the framework, they're really simple, right? But that doesn't necessarily mean that they're easy to implement. And I love talking about this stuff, and it's really kind of a challenge for me to boil it down into a couple of slides, but I'm going to try. So the first step, and this is kind of one of the most important things, is that we want them to elicit a prediction. Really kind of the base summary of this entire process is that the best way around this problem is that if they come up with it themselves, right? We want to try to encourage them to come up with the idea of the new way of going about this themselves, and then to encourage that. So this is a process to try to help that come about, right? So the first step is elicit a prediction. And this is, you want it to be a testable prediction. So this is the person who comes in and says, I can't bend over and touch my toes, or I can't bend over and pick something up from the floor, because when I do, bad things are going to happen. Okay. So a lot of times we just move along from there. But what this says, this idea of eliciting a prediction, is take that a bit further. What is the thing or the things that you're worried about are going to happen if you do this? What's going to go wrong? Or a simple way that you might ask that question would be to say, okay, if you were to do that, what would happen? Just to get a little bit more specific about the things, the more specific part of what it is they're worried about with that pain. They're probably going to say, I'm worried that it's going to hurt, right? But you need to dig a little bit deeper to try to say, what is that pain a surrogate complaint of, right? When it hurts, right, what's that going to look like? Are you going to have less motion? Are you going to not be able to do certain things? Are your symptoms going to change in a predictable way? And there are lots of ways you can get specific about this. Again, we're kind of limited with time with how much we could get into this, but you can use different outcome measures to kind of help come to these things. I like to use the patient-specific functional scale, which is a real simple kind of 4-question in their own words. What are the things that this is really having an impact on? And then you can tack on to that extra questions like, what would be the bad thing that would happen if you were to try that? And you can tack onto that additional frameworks like graded exposure, exposure-based therapies, and things like this. Okay. So now that you've got them to describe a particular thing that's going to happen in a particular way, now you've basically come up with a testable hypothesis. Right? So the second step is to set up an experiment, a way to test that prediction. And what's important about this step is that you are setting up the experiment in a way to give your best bet, your best attempt at showing that prediction is false. Right? You are trying to refute that prediction. More importantly, you want them to refute that prediction on their own. Right? So they've come up with the prediction, what the bad thing that is going to happen, what that's going to look like. And then you're going to set up the experiment that they're going to go through themselves. And that's the most important part of this, is that they need to be the one who actually runs this experiment, because they need to see that the prediction, the thing that they said was going to happen, didn't happen in the way that they thought it would. Right? What we're looking for here is a surprise. Okay? And we're going to go through some more specifics of this, but we want to set up a surprise. We want them to be thinking, that's not what I thought was going to happen. Why is that? Right? And if we go back to our pain science education, our information, that is probably the right place, or the most impactful place to use that information. When that person says, boy, I didn't expect that. Why did that happen? Now they're not looking for confirmation of something they already believed. They're looking for an explanation of why the thing they predicted didn't happen. right? Then you've got a really good chance to make a change with your information. So that is something that when I hear that, I know that we are about to move into really fruitful ground. Any kind of why question, especially, but especially when it comes along with that degree of surprise. Okay. So then the third step is building confidence. Building confidence that result that they had wasn't a fluke, right? You want them to kind of repeat the experiment in multiple repetitions so that they can see that they can do this consistently. They're going to build confidence in the result that they got. So what I really like about this, so this is consistent with, this is one of my favorite papers maybe of all time here. This was Michelle Krasky and her group. They came out with a paper in 2015 on exposure-based therapies. And, one of the big problems with graded exposure programs over time has been this problem of they can extinguish the fear that's associated with the particular thing, but it reinstates itself later on. There's a big problem with reinstatement of fear and graded exposure. So this ordering of approach, or the concept of trying to refute their expectations, was what Krasky and her group have found and are stating is probably the most important thing as far as the length or how long the result of your exposure are going to last. And I will say this whole approach of edge work, novel movements that we're going to go about, I do feel is consistent with this idea of an exposure-based therapy. The other thing I really like about this is that this framework is really just consistent with the best method that we have available to us as far as getting around our biases, and that's the scientific method, right? And in the scientific method, the goal is not to confirm a hypothesis that you already think. When you set up an experiment using the scientific process, it's about falsification. You have a hypothesis that makes a predictable, testable outcome, and then you do your best to try to prove that wrong. And if it survives, then it survived the refutation, and you can have a little bit more confidence that theory is not wrong. Okay, so I really like that it's consistent with a couple of pretty important things here. Okay, so that brings us to edge work, one of the actual processes that I like to use for this. So what edge work is, real quickly, kind of a summary of this, it is this concept of you're helping somebody identify a reproducible scenario in their movement or in their function, so that then they can apply something else at that place, so they can work on something there and hopefully bring about noticeable change. Okay, so in real simple terms, what you might have somebody do is move through a motion. Let's just think of a simple movement that you might have somebody try, where they take it out to their first signs of any kind of protective behavior. And that's exactly how I'll describe it to people. I'll say, I want you to move out to kind of the first thing you feel like is protection, the first protective thing that you feel. I don't want to give them too much information about what I think that is, because they're the only ones that can feel it. I want it to be in their terms. But that might be a change in breathing pattern. It could be a change in the tension that's associated with the motion. It could be pain. It could be lots of things. It could just be a feeling of unease. They might just feel like they're not safe going any further. Whatever it is, I want them to go in that direction in a manner that they can pick up on the first signs of that. Okay? And then what we do is we actually practice finding that scenario and moving away from it, and doing that over and over and over again, so that they can really get good at finding that point. Because a lot of times what people do is they either avoid it, they don't go near it, or they plow through it. And the idea of going slow enough that you can find that subtle beginning of the edge is because when you're at that point where the changes are subtle and they're small changes will be more noticeable, right? If they plow through it and they get to a point where they're really deep into these sensations and it changes just a little bit, they're probably not going to notice it a whole lot. But if they're at the very beginnings of it, where those changes are subtle, the idea is that hopefully they'll notice it more specifically. Okay, so once they get good at finding that scenario, and I should say too, I'm going to back up 1 second. I usually start at that point, the beginnings of it, but you don't have to work there. One of the big misconceptions about this is that it has to be a totally pain-free or symptom-free approach, and it doesn't. What's important is that it's reproducible. So as a person has a feeling of more safety, more security of what their symptoms are and how they can control them, I am fine with them going further into it. The important thing is that it's reproducible so that they can notice change. Okay. So once they get good at finding that edge, wherever that is, then the next thing we add to that is some experimentation, right? We want to set up an experiment that they can prove their prediction wrong. So at that point, we'll add some things like, something as simple as diaphragmatic breathing even, or we might add in some neurodynamic type motions where we're putting on tensioners or we're doing sliders. Really, there's no limit to the things you can do here. And when I teach my classes, I tell people, a lot of the stuff that you're going to do here is stuff that you're already doing. This is not the type of thing where you're learning a bunch of new methods or new specific exercises. I give some models for them to try, of course, but really, it's more a framework of how and when and where you apply the things that you already do most likely. Okay, so then I kind of tend to cut these things out into a few different categories. So nudging, we go to the bottom bullet point here. Nudging is when you move up to and away from the edge. So they're going up to that scenario, away from it, up to it and away from it, over and over and over again. And what they're looking for is change. And hopefully as it changes, it gives them more motion, or they have to go further into the motion or into that scenario before they get to that same scenario of sensations. So hopefully they're seeing an expansion of what they've got available to them. And when they do, they just keep taking up the slack. Okay. The second one is following the edge. So these are more kind of circular type motions usually, where I might have a person they move out to an edge and then they stay with it through a motion. So I might have somebody doing like a big wall circle as an example, where they kind of go up to a point and then they kind of almost trace the edge of it around the circle. The third one is stacking the deck. So this is where we go up to that point. They go to the edge where they're going to work, and then they add something else to it. This could be your manual therapy. It could be diaphragmatic breathing. You could do multiple things where you're trying to incorporate some concepts of exercise-induced hyperalgesia, which, basically for me means you're adding an isometric exercise or some kind of resistance there. There are lots of things that you can do with stacking the deck, and that's where it kind of gets fun to play around with this a little bit. So a few examples of each of these, again, just to kind of give you some things to walk away with and try in the clinic. So nudging. So one thing you can do is this upper limb neurotension test 1, that kind of position, like a sliding maneuver, right? So, and you can try this while you're sitting in your chair even if you want. So you kind of get yourself into that position. You lead out with the fingertips and you go slow enough until you kind of get to that first point of tension, right? Or again, whatever is the first thing that you feel. And at that point, you move away from it. So you just curl your fingertips back and then back towards it again. And you do this multiple times. It's a lot like a tensioner, right? And as you do this, most likely the intensity of that sensation, whatever it was, will lessen. And when it does, you just go a little bit further out and you find it again and you repeat the process. Okay. So another one that I use really commonly as kind of a first point of education of teaching people this concept is I'll have them lie on their back with their knees bent up, and I'm just going to have them rock their knees from side to side like windshield wipers. So this is most likely somebody who has back pain. And again, we're looking for that edge, whatever it is they consider it to be, and then they might just bump right into it either side, again like windshield wipers. Okay. Similar to the upper limb tension motions, there's slump position tensioners. You can have them in a sitting position, slumped forward. Again, they kind of raise they're going to extend their knee and dorsiflex and run into that edge and back off of it over and over again. Another one would be quadruped rocking. You might have them rock back till they get to that sensation over and over again. Okay, following the edge. So again, think circles. This might be I have people doing a lot of sliding circles on walls with their arms. You can have them doing scapular clocks. You can have them doing hula hoop motions. The important thing is they're just trying to trace the line of that edge through a motion, right? And so sometimes I might call this like you're trying to wipe it away. Like hopefully as they repeat repetitions around the circle, it kind of keeps widening a little bit is what we're looking for. Okay, stacking the deck. So again, this is where you go to the edge and then you add something to it. Isometrics, I love using isometrics at this point. Diaphragmatic breathing, as I mentioned, that's a really simple one. That's not a bad one to start with, just because for one, it's really easy to do. And for two, a lot of times they'll see some change with it, which kind of de-threatens the scenario to begin with. If this was something so bad, how would something so simple as breathing make a difference in what they're feeling? Okay, and then if you want to use manual therapy, if that's your thing, this is a good point that you could do that as well. Okay. Okay. So then the next part of this, excuse me, kind of another approach that I like to use with this is this idea of novel movements. And I've always used to describe this as kind of a change of an opinion. It's like your body has an opinion of a movement as being bad, and so it's very protective of it. And a novel movement is a movement that your body doesn't have an opinion of yet. But I've kind of sensed, it's not that I don't like that definition anymore, but I really have kind of moved more towards a novel movement is just basically a different way of doing the same thing, right? So it is if somebody has trouble bending forward, we're trying to get them into that forward bent position just from a different route, and hopefully one that is not protective, right? So it's like we create a different pathway, or we create some flexibility in the way that they can get to this thing that has been troublesome for them, and then you can build from that. Okay, so again, I break some of these things down into categories. A couple of simple ones are reversing the order of motion. So the scenario I just described, where they have trouble bending forward, you might have them kind of go from a chair and getting into a squatting position and then stand up. So they're going kind of through that forward bent motion, but they're doing it in reverse. You might have them rotating their trunk underneath their head. So this would be somebody who maybe has pain with neck motion going side to side, rotation wise. So you might have them keep their head still and rotate their shoulders underneath their neck. So they're still rotating their neck. It's just happening from below. Okay. You can alter the force vector. You can change, you can take a motion and exaggerate or reinforce either the eccentric or the concentric portion of the motion. So as an example, if somebody has pain with reaching overhead with their hand, what you might try is putting your hand under their elbow and have them keep a little pressure down into your hand as they let their arm move into that flexed position. That's an example of how you might make that change. Another one would be with knee extension. If it hurts for them to extend their knee, you might put your hand behind their heel and have them keep a little bit of back pressure as they go through it. And then, another one, moving while holding against another force. So this might be, you might keep a little bit of lateral force on their wrist as they raise their hand into flexion. So they've got a little bit of external rotation force, just altering the vector in some way. Again, it's the big concept here is that you're trying to get them into that same position or into that same motion or activity, just in a different way somehow, in a way that makes the change that you're looking for. Okay. The third one I have listed here would be reversing between the open and the closed kinetic chain. So this would be somebody, again, whose hand, who it hurts when they raise into their shoulder into flexion. What you might have them do, instead of letting that hand move freely into space, is have them plant it on a wall and put some pressure into it and then squat. So they're keeping some pressure through their hand, keeping that in the closed chain, but still they're getting into that shoulder flexed position. Okay, and I'm sure you guys are probably all doing a lot of this stuff, or maybe all of it and more, in your practices already. Again, the important thing here is applying this to that 3-step framework. Having this being working towards a prediction of something that they felt was important, that was going to go wrong for them if they try these things, and having this be a way to show them, or for them to show themselves, that bad thing didn't necessarily happen. Okay, and what most likely is going to occur at that point is not them just totally abandoning their belief, they're just going to move it in the direction that you're looking for a little bit. And then they've got new predictions that they're going to make that are altered a little bit, and you repeat the process. Okay. Oh, we got sideways here. I'm going to go ahead and try to play.
Yeah, I think when you play it, it'll revert properly.
Okay, good deal. So I got a little video here that I shot of just kind of working through some of these things just to give you an idea of what we're talking about. So let's see here. I guess you will have to look at my ugly mug a little bit. Oh, I don't think we have sound. Well, shoot. Okay, well, I guess we're going to skip the video because it's not going to do us any good if you guys can't hear it. But let me kind of talk you through what was going to go on in this video. So I'm walking through a really simple progression of how you might work with somebody who has something as simple as pain with bending forward. Okay. And again, I wanted to keep it really simple because that kind of helps hopefully drive home some of these things versus a real complex scenario. So where I'm probably going to start with them is I'm going to have them laying on their back and going side to side with their knees, and kind of working on figuring out what this whole concept of finding the edge is. And at that point, I'm going to show them some of the first concepts of nudging and breathing at the edge and some of these other things. Next, what I might have them do is get onto hands and knees and go into a quadruped rocking type position. For one, again, that reinforces the concept. It puts it in a little bit of a tougher position. But also, at that point, you can point out to them that they are in a position of hip flexion and lumbar flexion, similar to being bent forward, right? So if their prediction was, bad things happen to me when I'm in a forward bent position of any sort, this already functions to start refuting that concept, that prediction, right? So it might not be in standing, but they've now shown themselves that they can get into that position in another way, right? So that's a beginning, that's a starting point for this. Okay, so then the next thing I might have them do is, once they've worked through that, is have them sit on a chair, and this is what was going to be shown in the video. And what I'll have them do is just scoot out to the edge of the chair, and they're just going to run their fingertips kind of down the front of their legs, going slow enough that they can identify where their edge is. Okay, and then you might have them nudge. You might have them work up to that point and away from it a few times. You might stack the deck where you have them go to the edge and then add diaphragmatic breathing. There's a lot of things that you can do there. You might have them, for example, you could have them add isometrics at this point. You might put your hand on their shoulder, have them push to the side, and hold it for 30 to 45 seconds, and do that for a few repetitions, and see if you can get some of that exercise-induced hyperalgesia effect. But regardless, you have them repeat that process until hopefully they're making some gains. Then the next step is, if they can once they get to the point where they've shown themselves they can get into a forward bent position in sitting, now you want to progress that to where you're trying to refute that prediction in standing, because that's what's more important to them most likely. So what I'll have them do is, I'll start the same way. They slide their hands down the front of their shins, and when they get low enough, they just shift their weight forward enough that they actually come up onto their feet. Okay, now at this point, they're basically standing in a forward bent position, right? So this is like a novel movement where they've gotten into the same position, they've just done it a different way. They didn't stand and reach for their toes. They got towards their toes and then they stood. All right, so still not exactly the scenario that they were talking about, but now at least they've shown themselves that they can in fact get into that position safely. Okay, then I have them start working their way up towards standing. Right, so then they kind of, once they're on their feet, then they start sliding their hands back up their legs like they're coming towards upright. And you repeat that process as often as you need to get them to where they're standing fully upright. At that point, you repeat the process, going back down their leg. So now they're finally starting to work from standing and going right towards forward bending. But now they've got a context to work on that in because they've already done it in the reverse order. So that is a kind of a simple scenario of how you might use these concepts to work through a progression of motion that is important because it is specific to the prediction that they've made of the bad thing that's going to happen with the motion that's keeping them from doing the things that they need to do. And they've shown themselves that the bad thing that they expected to happen didn't happen, right? And then the third step is you just have them practice this. You want them to build confidence in the result. And as they do, you just keep making it tougher. You keep kind of changing the experiment setup to be more and more like the thing that they need to do. Okay. So with that, I think I'm going to wrap up here. Just a couple of other resources. I do have a few blog posts that kind of spell some of these things out in a little bit more detail. Like I said, I do have a couple of online courses that are available here as well. Anybody who's interested, I'm actually going to be in Vancouver, British Columbia this next weekend giving a 2-day course. It's kind of coming up quick, but if anybody's looking for more information on this or just looking for a course to take or wants to visit Canada, you can come up and see me in Vancouver. We'll watch some hockey and drink some maple syrup. So yeah, Kristen, do you want me to, there's a couple of questions that came up here. Do you want me to go ahead and get to those?
Yeah, that would be great. Do you see those there?
Yeah. So Jeff asked if there was a useful pain survey or questionnaire I like to give to new patients. I really like the patient-specific functional scale. I like it because it's so simple. It's a 4-question survey, and you don't even, a lot of times I do it, we don't even get 4 survey results. Maybe we just get 2, but it's in their own words. What are the things that are really important to you that this is keeping you from doing? And it allows them to rank it from 0 to 10, kind of how much of an interference it is on their normal valued living. So I really like that one. Some other things that might help you through this, there's as far as the graded exposure approach goes, there's a questionnaire called the Photos of Daily Activities. And really it's a set of pictures. And basically what people do is they pick out the pictures that are relevant to their situation and they place them on this thermometer of how important it is to them, or how distressing it is to them. And in the graded exposure approach, you start from the bottom one, the easiest one, and you work your way up towards the tougher ones. Another thing with the Kraske results on exposure-based therapies is that real strict approach of a progression, you have to work through a graded hierarchy, might not be so important after all. Really, you can kind of let the patients guide what's the next most important thing to work on. So I really like those because they're so simple and so easy to use. Also in the on-site setting where I work a lot, there's not, I don't have a great big intake packet that I have people fill out. There's just not the setting doesn't allow that so well. But that's the one that I would use. Let's see. Larry asks if this method tends to work better with acute pain, chronic pain, or does it matter? My feeling is that this process is going on regardless of where they are at. So most likely, a lot of times we see a lot of people in acute pain in the on-site setting. People are coming in and usually they're more worried about, does this thing mean something bad? They might come in and this isn't keeping them from doing anything. They're working normally. They're doing all the stuff they normally do. It's just an annoyance at that point. And they just need reassurance that the thing that they're dealing with is not something for them to worry about. But even when it's that super simple presentation, I still think it's the same concept. There's a prediction that needs to be refuted, and they need to show themselves that it is. And a lot of times you can go through this exact same process, and them just seeing that they can change, that they've got some control over their symptoms is enough for them to see, okay, this is not something I need to worry about. And then they just kind of get on moving normally. Their self-efficacious behavior kind of takes over, and that's what we really want. I think where you got to get a bit more specific, or you got to maybe gather a bit more information, are some of the more complex presentations, like the folks with persistent pain, or people who, they might be in the acute scenario, but they've got a lot of narrative indicators that they're coping very passively, that they don't have good expectations of recovery. I mean, you can kind of see the writing on the wall sometimes, even in acute presentation, where these things are going to be really important. So I feel like it's the same. I feel like it relates to both. Just kind of how far into some of your questioning you go might vary based on the presentation a bit. So, yeah, I want to thank everybody for listening. If anybody else has any other questions, feel free to throw them out there. But I really appreciate everybody listening, and I hope you got something meaningful out of this.
Yes, thank you, Cory, and thank you for everyone for participating.
Yeah, and I just wanted to say thank you to Kristen and to Workwell for giving me a platform to talk about this stuff. So thank you.